welcome everybody to the latest in the ADNeT Memory Clinic webinar series. This one's entitled Sleep Disturbance and Dementia, and we've got two great presenters and great presentations. And just a reminder that a recording of this and previous webinars are all available on our YouTube channel, and this will probably be up a week or so after the presentation today. I'd like to start by doing acknowledgement of country. The ADNeT acknowledges the traditional custodians of country throughout Australia and their continuing connection to land, sea and community. We pay our respects to all Aboriginal and Torres Strait Islander peoples, their culture and to their elders past, present and emerging. Hopefully most people by now know ADNeT, but for those who are joining us for the first time on this webinar, ADNeT is the Australian Dementia Network. It's a collaboration of 15 institutions across Australia, set up by an $18 million NHMRC grant back in 2018. Really set up as a network of national dementia research experts. And it's got three main initiatives: ADNeT Registry, ADNeT Clinics, and ADNeT Trials. So ADNeT Trials is all about establishing a national clinical quality registry for dementia, the first time it's happened in this country, establishing both from memory clinics, then eventually from primary care. ADNeT Clinics is the memory clinics initiative, including where this webinar is originating from, and it's all about harmonizing standards, maintaining standards, and establishing peer support and networking across Australia. And finally, the final arm is ADNeT Trials, which is about establishing and maintaining a highly characterized trial-ready cohort of people at risk or people already with MCI and dementia to try and speed up diagnostics and new therapeutics. So if you haven't already, please would you consider participating in the ADNeT registry and also joining our list of memory clinics and services associated with dementia assessment. So this is available online through the ADNeT website. We've got over 100 clinics and services listed now that people, either GPs or other specialists, can search. And we're improving that search all the time. So it'd be good to list your service and make it available if possible. So in terms of the webinar today, if there are any difficulties, please select your raise hand button and one of our moderators will contact you and try and address the difficulty. At the end, there's going to be a Q&A session where you'll have an opportunity to ask Simon and Sharon some questions. So you can either post under your name or anonymously, and we will ask those questions. And then afterwards, please would you go on to participate in the feedback survey, which helps us shape future webinars. So your feedback is important. And also at that point, you'll get a certificate for attendance. So without further ado, I'll introduce our two speakers. So Professor Sharon Naismith, the Leonard P. Ullman Chair in Psychology, NHMRC Dementia Leadership Fellow at the University of Sydney. Her multidisciplinary work focuses on the modifiable risk factors for dementia, such as depression, sleep disturbance, and cardiovascular disease. She has co-authored more than 294 papers in leading specialist and broad-based journals, and is a chief investigator on competitive grants totaling around $31 million. She leads the Memory Clinics initiative of the Australian Dementia Network, as well as the NHMRC Centre of Research Excellence to optimize sleep in brain aging and neurodegeneration. She chairs the Sydney Dementia Network and is vice chair of the Alzheimer's Association International Sleep and Circadian Rhythms Professional Interest Area. And then we have Professor Simon Lewis, Professor of Cognitive Neuroscience and an MHMRC Leadership Fellow at the University of Sydney as well. Professor Lewis is the Clinical Director of the Aging Brain Clinic and Director of the Parkinson's Disease Research Clinic at the Brain and Mind Centre, and heads the New South Wales Movement Disorders Brain Donor Programme. Prof. Lewis has published over 200 peer-reviewed papers, 2 books and 8 book chapters, and has attracted over $5 million in funding from various sources, including the NHMRC, ARC, and the Michael J. Fox Foundation, to support his research interests targeting quality of life in neurodegenerative diseases.
Thanks very much, Matt, for the very kind introduction. It's always great to be here as part of the ADNeT seminars, but in particular to talk about sleep, which, as you can see, I'm very passionate about. So what I hope to talk to you about today is really looking at sleep in Alzheimer's disease, how it may be linked to Alzheimer's disease and early forms of Alzheimer's disease, and what we can do about it. And hopefully I can convince you that we all should be paying more attention not only to our own sleep, but also for screening sleep and asking about sleep in our clinical practice. So what I'm going to do is just run through a few different areas. Firstly, just to introduce you to what sleep looks like when we look at the hypnogram or architecture of sleep, and how does that change with aging. And then I want to convince you with a few epidemiological studies that there does appear to be a link between sleep and the future development of dementia. Then I want to hone in a little bit more specifically on the types of changes that you'll see in sleep with dementia and MCI and how these link to different neurodegenerative markers. And then what can we do about it? What are the different screening and treatment options that we can use in our practice? So first of all, this is what we call a sleep hypnogram. So you can see here in a young adult that our sleep starts out here in the black period where we're awake, and we cycle down in 90-minute periods through different stages of sleep. So we start with very light sleep, and then we go into stage 2 sleep, and then we fulfill these nice deep stages of sleep. And we tend to do this in the earlier parts of the night, and to have more of the REM sleep or the dreaming sleep in the latter parts of the night. But what happens when we get older is that it tends to take us longer to fall asleep. The duration of our sleep reduces often. We tend to have more nocturnal awakenings. So on the hypnogram here for the older adult, you can see that there's lots more of this light sleep, and also there are more of these black periods, so more awakenings during the night. And our sleep tends to be more fragmented. So we go in and out to different sleep stages and tend not to stay in the same one for as long. Importantly, we have less of this nice deep slow wave sleep or slow wave activity that is restorative and is important for maintaining homeostasis in the brain. And so we tend to have much more of these very, very light stages, excessive daytime sleepiness, and in turn, we may have increased daytime napping. So around 10 to 50% of older people certainly may nap. And the other thing that we see is advanced circadian rhythms. So this is an advance or a shift towards earlier sleep times. And in general, this is controlled by the circadian rhythm and controlled by light and dark cycles, where we have the suppression or the increase of melatonin according to either light or dark. And there are many factors that influence this from the environment as well. And so why is it important to consider this link between sleep and dementia? Well, many of you will be familiar with this particular figure that shows many of the degenerative changes or changes in the brain that are occurring before the onset of dementia. And certainly work by the ABLE study here in Australia has very eloquently demonstrated that some of these changes occur up to 10 or 20 years even before clinical symptoms emerge. So it's important that we start thinking about factors that can impact on the progression of the disease in these very, very early stages, particularly since some of the disease stages like MCI are ideal for thinking about secondary prevention. And importantly, we know that in all of the major dementias that sleep disturbance is a key feature. So it may well be the case that neurodegenerative disease leads to sleep disturbance, but I guess a key unanswered question is whether sleep disturbance actually precedes the onset of dementia. So here I'll be focusing mostly on the Alzheimer's and vascular dementias, but Simon will talk more specifically on dementia with Lewy bodies and the synucleinopathies. And we can see that there are many different disorders of sleep here in the green. So we may have formal disorders such as REM sleep behavior disorder, obstructive sleep apnea, insomnia, or advanced sleep phase. But we also may have less specific symptoms, such as just having not great sleep efficiency, sleep being too short or too long, daytime sleepiness, or just general complaints of poor sleep quality. And so what evidence do we have that sleep disturbance may precede the onset of dementia? Well, there's certainly been a lot of epidemiological studies. The downfall of these is that they've generally used self-report instruments, which is of course common in epidemiological studies, but certainly recent syntheses of these have shown that of 18 longitudinal studies of nearly 250,000 people at baseline and nearly 26,000 people or dementia cases at follow-up, those with sleep disturbances certainly did have a higher risk of incident all-cause dementia, Alzheimer's and vascular disease, relating to about a 20% increased risk. Sleep duration has also been something that's been studied a lot. There have been a range of meta-analyses looking at sleep duration, showing that both short and long sleep duration are associated with an increased dementia risk. Certainly some more recent studies have shown that short sleep duration in particular is of concern. I mean, I guess one problem with many of the studies looking at sleep duration is they haven't been able to control for many other confounds. But this recent data from the Whitehall study has received a lot of attention. It actually followed up nearly 8,000 people from middle age, and 521 of those developed dementia after 25 years. And they found really that the sweet spot was around 7 hours per night. And this was associated with the lowest risk of dementia, but actually if you had much shorter sleep durations than that, then there was a 22 to 37% increased risk of dementia. And this was actually apparent after controlling for multiple potential confounds such as cardiovascular disease, mental health factors, etc., but was most pronounced for shorter sleep durations. The authors did actually repeat these analyses, excluding people that had mental illnesses, and also looking at those that had accelerometry data, so actigraphy data, with that being showed here. And that was available in around 3,000 people, and they showed those relationships still held. So what about obstructive sleep apnea? That's the other big one. Certainly a number of epidemiological studies have also supported this link. So there's the Hitler-Laus community study where they examined nearly 600 people aged over 65 and showed that cognitive impairment was independently related to the AHI, the apnea-hypopnea index, as well as the oxygen desaturation index. Our colleagues in San Francisco, Yue Leng and Christine Yaffe, did a great meta-analysis that was published in JAMA Neurology, and that actually examined a range of population-based studies and found that there was a 26% increased risk of developing cognitive impairment for those that had obstructive sleep apnea in middle age. And also our colleagues in the US, Ricardo Osorio from NYU, they examined participants from the ADNeT cohort, and they actually found that cognitive decline occurs earlier in people that have sleep disordered breathing, although once you actually have a diagnosis of dementia, the impact is less clear. So if we think about the patients that we're likely to see in the memory clinic, what does the sleep change that we see look like? Well, generally you tend to get an exacerbation of the types of changes that I showed you occur in aging. So much more of that light sleep and fragmented sleep. Sleep apnea is extremely common, with 70 or 80% of patients having an apnea-hypopnea index greater than 5, so that's at least mild sleep disorder breathing, and almost half having an AHI of greater than 20, so more moderate to severe. Studies that have actually examined the EEG features of sleep in more detail using power spectral analysis have shown that people with Alzheimer's disease have reduced and poorly formed sleep spindles. So these are discrete neurophysiological events that occur while we're sleeping. They're generated in the thalamus, in the reticular nucleus, and they actually coordinate and synchronize with a whole range of other rhythms such as slow wave activity. And a key function of these sleep spindles is actually to lay down our memories while we're sleeping, but also they play a role in conjunction with slow wave activity, probably in processes like synaptic pruning and downscaling. Many of you will know that certainly in the later stages of Alzheimer's disease, we get changes in circadian rhythm, day-night reversals, nocturnal awakenings, we get phase advances, and neuropathological studies have showed that this is probably related to degeneration of the suprachiasmatic nucleus, which is the master clock, and in turn to decreased pineal melatonin. The thing that's concerning about this is if we see an older person with sleep complaints or sleep problems and dementia, it's actually predictive of more severe cognitive decline and is often a reason for need for residential care. So we've been interested in seeing how this may relate to, or how sleep changes may occur in earlier disease stages, and we've really focused on people with mild cognitive impairment. We started out looking at self-report measures, and we found that even in comparison to controls that were seeking an assessment for concerns about their memory, so subjective memory complainers predominantly, people with MCI had more complaints of sleep disturbance, poor sleep quality using questionnaires. We then did more in-depth studies using accelerometry or actigraphy to look at more objective measures of sleep disturbance, and we confirmed there that people with MCI have more nocturnal awakenings, and these are related to poor performance on cognitive tests of executive and memory functioning. Using resting state fMRI, we've shown using both self-report and actigraphy that poor sleep relates to decreased connectivity or poor coupling between the temporal and parietal networks. And certainly there've been a whole range of studies looking at self-reported poor sleep quality, including those from the ABLE cohort from Stephanie Rainey-Smith, Belinda Brown, Ralph Martins, etc., that have shown actually that poor sleep is associated with increased levels of brain A beta as measured from PET scans. And a number of studies have looked at orexin, which is the wake-promoting neuropeptide, and have shown that people with MCI have increases in orexin that are similar to people with Alzheimer's disease, and are most pronounced in people that have sleep disturbance as well. The other component that hasn't been studied as well is actually circadian rhythms. And some time ago, Simon Lewis and I led a study where we looked at melatonin secretion and showed that there was actually advanced melatonin secretion in people with mild cognitive impairment. And in turn, this was related to their performance on tests of cognition. We've then followed this up by trying to examine using much more objective measures, so using polysomnography, which is the gold standard. What are the kinds of changes that we see when we use EEG to measure overnight sleep, and how do these change in mild cognitive impairment? So this was a meta-analysis of 10 studies, which included only 430 people out of those 10 studies. They're very difficult logistically to do and challenging. And we found that there was indeed a range of things that were altered in people with MCI, namely an increase in REM latency, so the time taken to reach the rapid eye movement sleep stage. Sleep time was reduced, sleep efficiency was reduced, there were more nocturnal awakenings. It took people with MCI slightly longer to go to sleep. There was an increase in oxygen desaturation due to sleep apnea, but we didn't find any changes in slow wave sleep or the apnea-hypopnea index. We've been interested in looking at these more closely. So in our own memory clinic sample, we've been looking at polysomnography measures of sleep and how they relate to changes in cognition and also in relation to key structural components of the brain. In this particular study, we had 83 people that attended our memory clinic. They weren't coming in complaining of sleep problems, but we found they had a moderate degree of sleep apnea. And the oxygen desaturation in particular was associated with bilateral thinning in the temporal lobes, which in turn was associated with poor performance on memory tests. We haven't had access to PET scans in Sydney, but our colleagues in the US have been looking at the ADNeT data and have showed that self-reported obstructive sleep apnea was actually linked to longitudinal increases in A beta PET in both normal samples as well as in people with MCI. And so I just wanted to really open up this concept of what are some of these key mechanisms and why might sleep be linked to dementia. And many of you might have heard of the concept of the glymphatic system. So in 2013, there was a key discovery about the glymphatic system, which really has provided us with a mechanism that we can explore now to see how we might be able to focus on targeting this glymphatic system in order to improve sleep. So I have a little cartoon here, which we developed in combination with Dementia Training Australia. It's a vastly simplified version of how the glymphatic system works. But I think it's nice, as we have a very mixed audience, just to give you an overview of what the glymphatic system does and why it's important.
We can think of sleep as being like a waste removal system for the brain. While we sleep, the brain's specialized waste system is activated to clear away harmful toxins and waste such as beta amyloid, which is a key protein implicated in the formation of plaques, a hallmark feature of Alzheimer's disease. In a healthy brain, cerebrospinal fluid flows along the periarterial space. As the brain's glial cells shrink and expand, the fluid moves through aquaporin channels to enter the brain's interstitial space where the neurons are. The fluid moves along the interstitial space towards the vein, washing away harmful toxins and metabolic waste. The fluid and waste then leave the brain along the perivenous space towards the lymphatic system. Since the glial cells of the brain moderate these processes, this is called the glymphatic system.
And so in this respect, we can then go back to the hypnogram that I showed you at the beginning, and you can see here in a younger person, you have this nice deep slow wave sleep at the beginning of the night, and you can see that this is the period of highest glymphatic flow. So glymphatic clearance is optimal in slow wave sleep, and particularly linked to slow wave activity, and then dissipates more in latter parts of the night. As we get older, as you can see again, there's less of this slow wave sleep here and less of this glymphatic flow. The other key thing that's important here is that the glymphatic flow is probably heavily influenced by the integrity of the cardiovascular system. And arterial pulsatility in particular propels the fluid flow in the brain, and is probably linked in some way to the glymphatic system that's operative during sleep, is probably linked in some way to cardiovascular integrity. And certainly that we know that the thickening of the arterial wall in small vessel disease, hypertension and diabetes, and this in turn may provide a mechanism by which cardiovascular disease impacts on the onset and accumulation of Alzheimer's pathology, though this is yet to actually be empirically tested. So I guess in a nutshell, there are lots of things that we're thinking about here in terms of the mechanisms by which sleep may impact on dementia. There's lots of things that we're measuring at a neurophysiological level, including these sleep spindles and slow waves. We need to think about oxygen desaturation and how various components of sleep disturbance impact on glymphatic clearance and in turn on the accumulation and onset of A beta, tau, and also white matter disease to contribute to dementia. So what happens in the memory clinic? What data do we have about the types of sleep disturbance that people may have? There has been a systematic review of all of the studies that were conducted in MCI, and that actually showed vastly different rates of obstructive sleep apnea, ranging from 11 to 71%. So the 71% is actually our clinic, and also 70% in the Korean sample, and this is because we're using clinical populations. But in the community studies where self-report's measured, you actually have much lower rates of OSA. So we tend to get the highest rates of OSA detected when we're using the gold standard polysomnography, and less so with self-report measures. So these are getting better, and there are other measures that we can think of now for screening for this. In terms of the other types of sleep problems, we don't have good data from memory clinics. We do know that memory clinic clinicians ask about sleep in clinical practice. We know that from the survey that many of you did, but we don't actually use tools very often to detect this. From our own data, we know that about 67% of older people have short sleep duration, about 41% have poor sleep quality. Insomnia is evident in about 51%. Again, high rates of sleep apnea, including hypoxemia, and also using screening measures, about 11% report REM sleep behavior disorder, which Simon will talk about more comprehensively. There are lots of things that we can do to screen for sleep disturbance. We do know, as I said, that many of you ask about sleep disturbance, which is really important. We can also use lots of self-report instruments such as the PSQI or the PROMIS, which is much briefer. We can then actually use more detailed measures such as actigraphy to look at the sleep-wake cycles, the nocturnal awakening, and also to really inform different management practices and decisions that we may use in a way to monitor sleep over time. There are lots of things that we can do to screen for obstructive sleep apnea, including using actigraphy and also things like WatchPat that are available now, and of course, referral for formal PSG as well. There are lots of treatments that we can consider, although I must say that there's generally a good evidence-based lacking for people with MCI and dementia. So we do have good evidence in many younger samples that things like CBTI work very well. And certainly there are digitized versions of these now, such as Sleepio and Shut-Eye. But in older people, we really need to build the evidence base using good quality randomized controlled trials. There are, of course, things like orexin antagonists that are becoming available, and also things like melatonin. So melatonin's a chronobiotic and antioxidant, and there are a range of different studies that have been conducted in MCI showing efficacy, improvements in sleep quality and cognition, and certainly doesn't appear to be associated with any major side effects. As I said, there's not a great deal of data on the psychological interventions. We did one pilot study that actually showed that CBTI is effective for improving sleep, and we need to do a larger scale study to look at the broader effects on cognition. Watch out for this study that we'll be conducting in Australia. So this is called the ReShape trial. We'll be screening for sleep apnea and treating sleep apnea using a very personalized approach. So not just CPAP, but lots of other approaches to try and get the oxygen desaturation index back to normal. Many other things are available. As I said, orexin antagonists, our group's looking at cannabinoids, exercise and cognitive training, and transcranial magnetic stimulation. There's also a lot of technology being developed, such as acoustic stimulation, which targets the slow waves in particular. So in summary, there are many sleep-wake changes that occur in the prodromal phases and MCI phases of dementia. We don't yet know if there are bidirectional links, but it certainly appears that there are sleep changes that do seem to precede the onset. There are multiple mechanisms that we need to unravel to get a better handle on this. And certainly we need better evidence, better clinical trials to show that treating sleep disturbance actually impacts on the progression of dementia. If you'd like any more information or access to scales or different tools, then feel free to contact us on this email. This is our Centre of Research Excellence. We are planning to look at in more detail the biomarkers and do more clinical trials and development of digital tools in this space. And I'd just like to thank our broader team of the CRE and also the Healthy Brain Aging team at the Brain and Mind Centre. Thank you.
So what I'm going to do is really talk about the concept of Lewy body dementias, and this idea of when dementia is all just a bad dream and nothing else is going on. This is quite important. So Lewy body dementias you'll have heard of and be familiar with, but it's a different sort of term. So I'm not just talking about Lewy body dementia. So this is dementia with Lewy bodies, which affects, as you know, a large number of older patients. And at post-mortem, it's said to be about 15 to 20% of cases will actually have DLB. Unfortunately, only about a quarter of those are diagnosed during life. The other Lewy body dementia that I want to talk about is that associated with Parkinson's disease. Again, not an unfamiliar and uncommon condition, affecting about 1 in 1,000 people, and certainly over the age of 60, about 1 to 2% of the population. And of course, the striking thing about Parkinson's disease, despite being a movement disorder, is the prevalence of dementia. So at any one time, about 25% of the patients that we see will have dementia. And if you do the longitudinal follow-up with these patients over 20 years, the vast majority of them develop a Parkinson's disease dementia. So we think about PDD, Parkinson's disease dementia, and DLB, those are our Lewy body dementias. And they're very important because they share common pathology. So as Sharon mentioned, a synucleinopathy, as opposed to tau or amyloid being the predominant change. The other thing that they have in common is this thing. So this patient is asleep. This is from the Mayo Clinic, a patient who's in a sleep laboratory. And we know he's asleep because he's all wired up, but he's in dream sleep. And normally you shouldn't do this. So this is dream enactment, known as rapid eye movement sleep behavior disorder, or RBD for short. And generally, this is something that shouldn't happen. We're going to talk about it obviously in depth today, but this is something that we see very commonly in the synuclein diseases. So this is a patient acting out his dreams, and if you were lying next to him, you'd have a rude awakening. So let's talk about these sleep stages. We've heard a bit from Sharon about them, and I guess the key one here that I've marked is this REM stage. And during REM, the brain is very active. So if you look at the cortical activity of the EEG during REM sleep, it actually looks like you're awake, but of course What's generally supposed to happen is that your body is supposed to be paralyzed. Your eyes can move, which is why it's rapid eye movement. The ossicles of your ears, the muscles that control those, are able to move, and obviously you can breathe. But the rest of you should be atonic, not stiff, but floppy, but not able to move. So when you look at a sleep study, you'd see the top two channels here. These are the eye movements. You see those big movements going around. The bottom two channels being some recordings from the brain leads, and then the chin EMG from mentalis, probably the most sensitive muscle to look for abnormal movement. This is an EMG. So these are the comparisons. So this is a normal sleep study where patients in dream sleep, you can tell their eyes are moving and their brain's active, but they don't have any muscle activity. If you compare that to REM sleep without atonia, which is what REM sleep behavior disorder looks like, you can see that EMG activity kicking off. And of course, if you really want to look for this, you can put on some extra leads and put them on the upper limbs and lower limbs and see if you can detect these movements, which can be subtle. So REM sleep behavior disorder essentially is characterized on video polysomnography as REM sleep without atonia. Ideally, one would like to capture some of that abnormal behavior on sleep studies to confirm it. You can listen out for a history of sleep-related injury, as you can imagine, it's quite prevalent. And you want to rule out other things that mimic it. So you want to see epilepsy, changes during REM sleep either, which would be a confound, and rule out other potential causes. So severe sleep apnea, people can come awake with a confusional arousal, and certainly medications and alcohol can also drive these behaviors. So as we mentioned, it's this loss of EMG atonia, and patients are very violent generally during their dreams, and the rates of injury are quite high. So about a third of them will either injure themselves or their bed partner. Falling out of bed is not something you should do after the age of about 4 years old. So if you hear that story in your patient, it's generally telling you that they're likely to have dream enactment behavior. It's more common, REM sleep behavior disorder in the community amongst men, and of course Parkinson's and DLB are more common amongst men. It's said that about 0.5% of the population have dream behavior. Well, of course, we know that 1% over the age of 60 have Parkinson's, and DLB would be a pretty high number too, and that rates go up with aging. So these are probably disease related. And as I mentioned, alcohol and certain medications, so antidepressants will be typical. So the tricyclics and the SSRIs can trigger this behavior, and people with high alcohol burden, especially late in the night. But the real key part is the association with synucleinopathies. So let's have a look at those numbers. So in Parkinson's disease, at least a third, maybe a half of patients or more will have REM sleep behavior disorder. And if you look hard with the atonia changes, you can really find it quite frequently. Dementia with Lewy bodies is even higher. So if you do the polysomnogram, pretty much all of them will have dream enactment behavior, and you can find it on PSG. And it's become, in fact, so important that it's become one of the core diagnostic features of dementia with Lewy bodies. So you can have that and other features to help make the diagnosis. And multiple system atrophy, another synucleinopathy, which doesn't tend to be associated with dementia, but also has a high rate of this behavior, presumably because the pathology affects the brainstem, which is normally the region that puts the body into an atonia. And it's quite interesting, the story of REM sleep behavior disorder, because the research on it has been about the last 15 or 20 years. But indeed, this guy called Parkinson, James Parkinson, wrote the essay on the shaking palsy in 1817. And this is what he wrote about case number 6. He said, when he always was in a state of agitation and alarm, so the patient's attendants observed movements during sleep that increased until it awakened him. So I think what we're really seeing is James Parkinson describing REM sleep behavior disorder here in one of his 6 cases. And I think it's really important to know how specific this behavior is. So this is a study of 172 patients who during life had dream enactment behavior confirmed by polysomnogram, and then went on to have post-mortem. And the numbers speak for themselves, and I'll just whiz through them, but the vast majority of these patients have a synucleinopathy. The frequency of dream enactment behavior in Alzheimer's disease, which of course can have some Lewy bodies in there, and other tauopathies, is incredibly low. There are some structural lesions. There are some very rare autoimmune conditions that can cause this. But generally, if you're listening and hearing that story and you're thinking about your dementia case, the likelihood is it's going to be a synucleinopathy. We heard a little bit from Sharon about predicting Alzheimer's and how sleep might help us to do that. And of course, we've got some other techniques, whether it's imaging with amyloid or CSF and tau and phosphorylated tau. And of course, more recently, blood tests looking at phosphorylated tau and the like. But and of course, by the time you get these things, you've generally got mild cognitive impairment. The issue with Parkinson's disease and dementia with Lewy bodies have a very similar looking table to this, is that we do know some risk factors that are associated with the risk of getting Parkinson's or DLB. So losing a sense of smell probably increases your risk by about 4 times. Being constipated, associated with an odds ratio or a risk ratio of about double. But if you look at that against REM sleep behavior disorder, it's not in the same ballpark. So if you've got REM sleep behavior disorder, your likelihood of getting Parkinson's is incredibly high. So this is important in terms of predicting, because this happens before you get any of the physical changes, and the same with DLB. And these are 2 studies, one European, one North American, which basically took cohorts of patients who didn't have Parkinson's disease, but actually had idiopathic, or was now known isolated REM sleep behavior disorder, and followed them longitudinally. And we'll have a look at, I think, the European study, and they had basically the same results, which actually showed that the vast majority of these patients over 14, 15 years, so 80% in this one, I think it was about 82% in the other one as well, developed a disease, a neurodegenerative syndrome. So you can see a sort of 50-50 split between Parkinson's and dementia with Lewy bodies, 1 patient with multiple system atrophy, which is quite rare, and 5 patients with mild cognitive impairment. Well, of course, if you've looked at the research criteria for dementia with Lewy bodies, you'll see that mild cognitive impairment with REM sleep behavior disorder has been proposed as a prodromal state for dementia with Lewy bodies. And to be honest, it probably is for Parkinson's disease as well, because a quarter of patients who are first diagnosed with Parkinson's have got MCI at that point. So clearly, these are patients of concern. And what's interesting from this particular study, when you look at those Kaplan-Meier survival curves, if you talk to the authors, they'll tell you they've been following these patients for a lot longer now, and pretty much all of them have transitioned. And in actual fact, at that point when they published this, 4 of them who were said to be healthy, neurological disease-free, but of those 4, all of them had abnormal dopamine scans, so reduced DAT scan uptake. Ultrasound of the midbrain technique, which is, it's a little bit hit and miss. I've done a fair bit of it. I'm not sure it's going to be very useful, but one of those 4 patients had change in their substantia nigra and impaired olfaction seen at 3 out of 4 patients. So of those 4 remaining, the likelihood is that by now they've already transitioned into something else. And this is the big collaborative study, the biggest that's been published. This is 24 centers, including our own, putting together 1,200 of these patients with isolated or idiopathic REM sleep behavior disorder and following them over time. And basically, again, the figures for transition neurodegeneration is there. About 6% of these patients will transition every year. And over this 12-year period, from this combined group, over 70% of patients had transitioned to have a synucleinopathy, about 50-50 between Parkinson's and dementia with Lewy bodies. So effectively, this is the strongest predictor, I think, of any of the dementias that we have, regardless of some of the other epidemiological studies that we see, because this is basically almost a one-to-one thing. So if you see this, the likelihood is your patient is going to go on and get a disease. And of course, at the time you see this, they may be completely otherwise normal with normal cognitive testing, normal physical examination. And we mentioned a couple of these other predictors of Parkinson's, and the same is true for dementia with Lewy bodies. We talked about hyposmia, so reduced sense of smell, and we didn't mention this one, color discrimination. So this is a terrible test where you have to arrange these pastel shades across the scale, as it were. And this has also been shown to be impaired in patients with synucleinopathy and a risk factor for developing synuclein disease. And of course, the other thing that we see in some of these patients with idiopathic REM sleep behavior disorder is that they may not tick all the boxes for making a diagnosis of Parkinson's disease, but they might have some subtle features. So just to give you some impression, this is a guy who, as far as I'm concerned, has a screamingly obvious Parkinsonian gait. But perhaps a less trained eye, I'd ask you to look at his arm swing and look at that posture of the right hand. Look at the way he turns. He looks like he's got a rod up the middle and he's turning on block. He's got a bit of reduced facial expression, but none of that would be enough to make the diagnosis of Parkinson's disease, because you have to see slowness. You have to then, in addition to that, of course, have either tremor and or rigidity, usually of cogwheel type. So the fact is, when you look at those 3 risk factors, as Ron Postuma over in Montreal did. They actually said, well, look, we know that there's a high risk of transitioning from this idiopathic REM sleep behavior disorder to getting a synuclein disease. What if we had a disease-modifying treatment that we could put into a trial? How many patients would we need to recruit? And this is based on that sort of how many patients would transition each year kind of a question. And if you look at what they did, was they actually stratified it and said, well, in this scenario where you have 3 abnormal features plus REM sleep behavior disorder, so if you're acting out your dreams, you've got maybe a reduced arm swing, your sense of smell is poor, and your color discrimination is poor, you would only need to recruit less than 100 people in each arm of that 3-year trial to be able to do a disease-modifying trial with good confidence. That's essentially a medium effect size. If you wanted a big effect size, or you were expecting a small effect size, you'd need obviously a lot more patients. So the truth is, even if you look at that chart, you'll see if you've only got one of those 3 things in addition to dream and act behavior, you're still going to need not that many patients to be in a disease-modifying trial to prove whether your disease-modifying treatment worked. Now, obviously, we don't have one of those yet. There are ongoing trials, especially in Parkinson's disease, for disease modification, even going on here in Australia. And if we found something that worked in those patients, then you'd be looking to do this international collaboration, which we are part of, to do a disease-modifying trial in iRBD. So now that I've scared you sufficiently, hopefully to have your attention, how do we find RBD? Well, the great thing is it's a question. So basically there is actually a questionnaire. It's validated. I think there are 12 questions in this questionnaire as a screening tool, which doesn't need to go into this. Basically, screen patients. If they score over a certain amount, then you might have a threshold to go and put them into a sleep lab, and you'll see it performs pretty well. But if you want to make life really easy, you can go to this, which is essentially a single question, which effectively is 4 questions bundled in one. But it's quite easy in the clinic to say to a patient, have you ever been told or suspected yourself that you seem to act out your dreams while asleep? For example, punching, flailing your arms in the air, making running movements. So if you ask that one question and get a positive response, you'll see that the sensitivity and specificity of picking up PSG proven RBD is very high. So in actual fact, this is dirt cheap. And it's the one question that if you've got someone with dementia in the clinic and you're not sure what they've got, if you ask this question, they say, yes, I do that. The likelihood is you're looking at someone, probably DLB in the dementia clinics, of course, or possibly Parkinson's. But effectively, this is really very robust. And if you wanted a bit more of a flow chart to go with it, this is a paper I published with Eli Matar a few years ago now, which basically says, look, listen out for the story and ask the question. If you ask the question and they say, yeah, I do that, put them in a sleep lab, ideally with a few extra leads on the arms and the legs, called a SINBAR protocol, and video, so that you can see what they're doing. If they show that they've got it, then you have to exclude, or dream enactment, then you have to exclude the mimics, the sleep apneas that we're talking about, and other non-REM parasomnias. But if they've got REM sleep behavior disorder, then you're looking to say, well, okay, is there a cause for it? Do you have medications that might trigger it? Are you drinking too much alcohol? And if you're able to moderate those and they're still acting out their dreams, then you start thinking, okay, goodness me, could this be a case of synucleinopathy in evolution? And these sort of patients that need to be sent along for a bit more of a specialist look. And I think I probably see most of the ones from New South Wales at the moment. In terms of managing REM sleep behavior disorder, that's kind of a bit of a moot point, because clearly the first thing to do is to make sure that you get rid of the exacerbating features, but also make the bed environment safe. So a bigger bed, less obstacles around for them to hurt themselves on. I've seen patients punch through glass. I've seen them fall out of bed, hit themselves on the corner of a table, doing serious injury. So clear the space, make it safe. And then the question comes down to, are there any medications? And the World Sleep Society basically have been recommending clonazepam and melatonin for years. However, last year, I think the Koreans, my mate BJ, Byung-Seok John, in South Korea, Seoul, did the trial looking at clonazepam in people with Parkinson's disease. So this isn't iRBD, but Parkinson's disease patients, and show that it didn't work for reducing REM sleep behavior disorder. This was only self-reported REM sleep behavior disorder patients who were recruited rather than confirmed PSG. But basically, I think clonazepam is unlikely to work. And as you know, it's not very good for memory and it's not very good for balance. So it's a drug that probably should avoid using. And then, of course, you think, well, let's do melatonin because that's nice and safe, natural hormone from the brain. And this is the trial that we did with Parkinson's disease patients and RBD. And cut to the chase, unfortunately, melatonin doesn't work for REM sleep behavior disorder either. So at the moment, I don't think we have any pharmacological options for treating REM sleep behavior disorder that we could recommend with any confidence. So there we have it. Take-away messages: REM sleep behavior disorder, very specific for synucleinopathy. It's a very specific predictor for Lewy body diseases, and just give it time, they generally transition into one of those. It's very easily screened for. You ask a question and then you send them off for a sleep study. In terms of symptomatic treatment, that's not so easy. And in terms of the opportunity for disease modification, well, we need to get something to work in other diseases, perhaps before we take it to that population with iRBD, to see if we can stop patients actually ever developing a dementia, which I think will be the closest thing we'll ever get to a cure, frankly. So with that, I'm going to pause. I'm going to use the opportunity to put a blatant plug up for the masterclass, Disease of the Age of the Brain, which I've been running, I think, for the last 6 years. We will still be going ahead, and if you want details of the course this year, which will probably be online, is in person at the moment, depending on what happens with the lockdown, but certainly be going ahead online, but the details are all there for you. So I'll wrap up there and stop sharing my screen, or perhaps, Joe, you can do that for me because I've lost my floating panel.
We've already got some questions coming through. We've got about 5-10 minutes for questions, not very long, but just for the participants, if you want any questions answered, please write in the Q&A and we'll try and get through as many as we can. So I think, Sharon, you've already answered some of them, but one was about the efficacy of melatonin in more severe dementia. Maybe you'd just like to address that to the group.
Yeah, sure. So I wrote a very long chat response to that one. So there is a meta-analysis looking at melatonin in Alzheimer's disease, which did show that there was efficacy for improving total sleep time. Yeah, obviously there was only 7 studies that were included in that meta-analysis, and they're of variable quality. So as usual, we'd say there's room for improvement in all of those. There's also been some in MCI. I can't recall the actual doses of the studies that were in the meta-analysis, but I do know the MCI doses range from 1 to 9 milligrams.
Okay. I had a question actually about CPAP. I guess you spoke a lot about obstructive sleep apnea. Are there any studies demonstrating that CPAP itself demonstrates an effect of cognition or longer term risk of dementia?
Yeah, look, the studies aren't great. There were some very early studies conducted by Sonia and Coley Israel in the US that had fairly small samples. We just conducted a study in RCT in MCI, and we showed an effect on memory, on verbal episodic memory in MCI. The adherence was quite variable, around 4 to 5 hours a night, which is common for CPAP users. In fact, you want to aim for more than 4 hours a night for adherence. There's a study in the US called Memories where they've ended up having to basically look at adherent versus non-adherent CPAP users. So it's not a randomized trial. And that's obviously because of the difficulties of randomizing people into no treatment or sham treatment when you know someone has OSA. So the ReShape trial will be the first trial really to look at using a much more personalized approach. So using goal-directed approaches, motivational interviewing, etc., using not only CPAP but splint, mandibular advancement splints, positional therapy, etc., to really just get the intervention right for the participant.
Okay, thank you. There's a big question here. Fabulous talk, Sharon, thank you. How do you define, identify and quantify poor sleep quality in the clinic?
Good question. So on the self-report measures, we usually use the PSQI, and we would just use a cut score of greater than 5, as is common in the literature. We also look at sleep efficiency, with sleep efficiency on actigraphy, namely being less than 85%. Ideally, what we want to do is use our data set now where we have 450 people with polysomnography and look at slow wave activity as well, because that's obviously a key feature not only of lymphatic clearance but also of sleep homeostasis and restorative processes. So I think at the objective level there's a bit more work to do there, but certainly most of the epidemiological studies have just used self-report measures like the PSQI.
Okay, thanks. Simon, a question for you, actually. It's relevant for me because a patient I saw actually earlier today. So I was asking about REM sleep behavior disturbance in a 65-year-old with some cognitive impairment. She denied, and her partner denied physical actions, but said she talks a lot in her sleep. So it's not just simple vocalizations, but it seems to be actively, talking for a period of minutes. Is that a sign?
So before everyone panics, what you have to remember is that you can do funny things in non-REM sleep as well. So a lot of the non-REM parasomnias, basically, I think the first thing I'd say on that topic is if you leave the bed, as in you're walking, the likelihood is you don't have REM sleep behavior disorder. So these people who sleepwalk, that's a non-REM parasomnia, put it to bed. Sleep talking typically is more likely to be a non-REM parasomnia, but the key part of it is to find out when it started. Often non-REM parasomnias will be there in children, and then it might go away a bit, and then adults can come back. So I think you have to keep an open mind. Usually with vocalizations with REM sleep behavior disorder, they can go on a bit. They don't tend to go on for minutes, and they're generally quite shouty and a bit violent-y. I've had one variation on that, which was quite embarrassing, which was the guy who basically screams out his first wife's name and they're in flagrante and during the night, and the second wife that he's now married to is not at all impressed by this, and I keep trying to have to reassure her that this is just the brain and he can't do anything about it, but it sounds like he's having such a good time, she just finds it vexing.
Thank you. Okay, there's a question about PTSD and associated RBD, which you've answered. I'll just give some time for anyone else to answer some questions. Sharon, you very efficiently already answered most of the questions in the Q&A. One of the things I only learned in the last few days, apparently now, you may all know this anyway, circadian melatonin is now available from pharmacists direct. It no longer requires a prescription. Though presumably still at the same doses.
Yeah, one of the things to do is to send patients to a compounding pharmacy and ask them to make up 100 capsules at that time. It's usually a little bit cheaper. And now that circadian's off, I think it's on the PBS now as well. So I think it's cheaper than it was, but worth exploring. I was also just going to mention about the confound of depression, because anxiety and depression, of course, can predate the synucleinopathies. Therefore, patients end up on drugs that give them REM sleep behavior disorder. So we don't have that completely wrapped off yet, and we don't quite know whether it's chicken or egg. I can see there's a complex question in the Q&A, Sharon. I think it's more for you.
So this may be, what do you think we have for dementia patients to be offered for major sleep disturbances, extends from clinics even to nursing homes, when non-pharmacological measures fail?
Good question. We actually did quite an in-depth analysis of some of the work that's been done in nursing homes and residential care through our program Sleep Matters that we did with Dementia Training Australia. I'm not convinced that there's been any good studies, aside from some light studies that have been conducted in the nursing home setting. Certainly the light studies have been helpful and shown that they work in terms of maintaining circadian rhythms, etc. I think there's a lot we can do still in terms of thinking about diet and napping and environment and comfortable bedding and noise, and really making sure that the time that is spent in bed is spent sleeping, so trying to optimize sleep efficiency. It's worth trialing things like CPAP and splint therapies for OSA. And there are, of course, patients that could still benefit from melatonin as well. And certainly the orexin antagonists, they'll be becoming more available, more widely used now. There is some data showing efficacy for sleep for those. But we do know that benzos shouldn't be used, or sedative hypnotics, for any more than a couple of weeks.
Okay. I think actually it was probably time to wrap up. So just before I go on to my final slides, thank you, Sharon and Simon, once again. That was excellent. And actually a few more questions have come on, which we haven't had time to answer, but maybe if you get time just before the end of the webinar. Yeah, so as I suggested, I mentioned at the start, there will be the option to get a certificate, and if you're able to give us some feedback following this, a survey will pop up, which does help shape the directions for our future webinars, and we can email you a certificate. The next webinar will be in 2 months in October, and that's going to be by Professor Li Fei and Emma, and it's going to be about cognizance, the cognizance program, and really post-diagnostic support, which is one of the major aims of the Memory Clinic initiative, is to try and improve that across Australia. And we'll send you an invitation and flyer in due course. Any questions, please contact the Memory Clinic team. And once again, Sharon and Simon, thank you. They were great, very clear, interesting talks. So thank you very much for that.